Greetings of the day. In the last part of the series regarding to the blast injuries, we are going to discuss about treatment in this video. So the treatment part of the blast injuries. So when blast injuries occur, they tend to be unexpected, right? So it occurs outside of regular working hours and often produce moderate to large numbers of simultaneous arriving casualties. Drills and checklists are critical for successful implementation of rarely used protocols. Checklists should be concise, never more than 1 to 2 pages, and available in location known to everyone. Implement the hospital plan for the management of the mass casualty incidents. Obtain details about explosion from patient and rescue teams. The nature and location of the blast, including size and type of the charge, occasion in open or closed space, structural collapse, associated fire or smoke, and toxic agent release will be helpful in making informed clinical decisions, especially with regard to the disposition of the moderately to severely injured casualties. Initiate triage as multiple patients arrive. Station an experienced emergency physician or surgeon at the ED entrance to triage patients to appropriate predetermined location in the ED or elsewhere in the hospital. Triage to categories of urgency using criteria such as those listed in this table. So the criteria for the triage in the bomb injuries are: when there is severely injured, they are triaged as a red, and when they are lightly injured, they may be considered for a yellow or a green triage. Okay, so red category includes airway, compromised breathing difficulty, hemodynamic instability, altered mental status, altered level of consciousness, vascular trauma, extensive second to third degree of burns. So we need to apply basic advanced trauma life support principles and like primary and secondary support within logistic limitations, but that may occur temporarily or permanently. Administer IV fluids and blood products judiciously, and preventing fluid overload is important for lung and brain injured patients. Consider tranexamic acid for uncontrollable bleeding. Copiously irrigate and disinfect wounds urgently, but definitive debridement and closure may wait for a few hours. Temporary splinting, traction, and dressing are generally sufficient for initial management of musculoskeletal injuries. Consider prophylactic antibiotics for severely soiled wounds, penetrating abdominal wound and thoracic wounds, and open fractures, and in patients who have diabetes or other immunocompromised states. So we need to address the pain management after life-threatening emergencies have been evaluated. Reserve opiates for patients with severe pain because opiate supplies may become limited. Patients exposed to open space explosion who have no apparent significant injury and normal vital signs and an unremarkable physical examination generally can be discharged after 4 to 6 hours of observation. We need to perform a secondary assessment of all casualties before discharge, and admit all patients with significant burns, suspected air embolisms, and radiation or chemical contamination, and abdominal signs, vital signs, and abdominal lung injury, lung examination findings, clinical or radiographic evidence of pulmonary contusion or pneumothorax, abdominal pain, vomiting, hypoxia, or penetrating injuries to the thorax, abdomen, neck, or head to the hospital. Patients appropriate for the discharge need proper follow-up instructions due to austerity of the initial care and propensity to miss injuries in a mass casualty incident. Because symptoms of pulmonary contusion and intestinal hematoma may take up to 12 to 48 hours to develop, instruct all discharged patients to return for re-evaluation if they develop breathing problems or abdominal pain or vomiting. Provide relevant follow-up instructions in writing, include audiologic and ear, nose, throat follow-up, wound care, immunization schedules, medications, and psychological support and social services. So these special considerations are needed, like in case of a pregnant woman and children. Because fetus is surrounded by amniotic fluid, direct injury to the fetus is uncommon. So injuries to the placenta, however, are more common after life-threatening conditions have been stabilized. Admit patients in the second or third trimester of pregnancy who have been exposed to the blast injury to the labor or delivery area for continuous fetal X monitoring and further testing and evaluation. Pelvic ultrasound, fetal non-stress test, monitoring, and obstetric consultation should always be obtained. Consider RH rhesus immunoglobulin administration if the mother's blood type is RS negative. And children may suffer significant tertiary blast injury because their lighter bodies are more easily hurled by the blast wind. Imaging such as total body CT may be difficult to perform in an anxious and frightened children and typically require sedation. And coming to the staff safety, so issues that may affect staff safety include possible infiltration of the ED by the perpetrators intent on causing a second explosion or attacks in the hospital, an unexploded explosive inadvertently brought to the ED, and transmissible disease in the setting of the body fluid exposure or needle sticks during stressful and rapid work. Contamination of the victims by chemical, radiologic and biological hazards, either accidental or intentional, caused by the perpetrators, pre-planned for such situations. And forensic issues. Police and crime scene investigators as well as counterterrorism and other security services have legitimate interests in securing forensic and other information. Efforts should be made to accommodate them, but never at the expense of medical care. Prior coordination with all relevant authorities should establish protocols such as who and how many persons from these agencies are allowed in, when, into which parts of the ED, who controls them, and who is empowered to limit their entry and work. As a rule, however, although a terrorist event is a crime, forensics in the hospital are of minor relevance compared with the actual crime scene. Investigators may wish to interrogate victims with minor injuries regarding the event and obtain shrapnel or clothing from the patients for forensic analysis. And also there is a requirement of information management too, because blast injuries are often a part of a large event. The information becomes a critical component of appropriate management. Such information concerns include clinical charting and other patient care centered information such as imaging, command and controlled information such as casualty flow data, resource management data, and interface with other agencies. Information provided to the relatives, and information provided to the media, information recorded for quality improvement and research. And an information center is an indispensable component of such events, providing a relief for the relatives and also preventing them from crowding patients' care spaces and impeding caregiver workflow. Thank you for watching. See you next time.